Welcome to the Derm Club podcast. Roughly 2 million people are diagnosed with cancer in the United States annually. Treatments with chemotherapy, immunotherapy, or radiation can be helpful in stifling or curing the disease. However, in many instances, dermatologic complications can arise from these harsh regimens. I found this to be a meaningful podcast for myself as I prepared for it because in my own family, I have two grandmothers, an aunt, and my own mother, all of whom are breast cancer survivors, and all of whom have undergone chemotherapy. When we send our loved ones out for those cancer treatments, we rarely think about the possibility that they might experience skin, hair, or nail complications post treatment. I myself was also a cutaneous oncology fellow at Boston University, where I experienced and worked with a lot of patients who were undergoing chemotherapy and had skin complications because of it, and we would treat them as best as we can. So, to discuss how complications can arise after cancer treatments to our skin and treatment options, we are fortunate to have Dr. Jonathan Leventhal, who is the director of the Onco-Dermatology program at the Smilow Cancer Hospital at Yale New Haven, and also happens to be the associate director of the dermatology residency program at Yale School of Medicine. Dr. Leventhal, welcome to the Derm Club podcast. It is wonderful to have you as a guest.
Thank you so much for having me. It's a pleasure to be here.
So let's start off by talking about what the typical timeline for developing skin eruptions after starting chemotherapy.
So that's a really great question. And a lot of it depends on the anti-cancer regimen that the patient's experiencing. So for example, if a patient undergoes chemotherapy, so let's say breast cancer, which is usually a type of what we call cytotoxic chemotherapy, then usually within the first several cycles or infusions in the first several weeks to even a month or so, they can start to experience some of these toxic effects. And so, for instance, for breast cancer patients on chemotherapy, they can experience hair loss, so complete loss of the hair on their scalp. They can experience various rashes, which can develop on their hands and their feet. We call these hand-foot syndrome or toxic erythema of chemotherapy. They can also experience lots of nail changes, including one that's especially distressing for patients when their nails lift up and they can develop infections underneath known as onycholysis and paronychia.
So I understand you said hand-foot syndrome and other areas. Is there a typical body area that has a higher predisposition to developing a skin eruption?
Yeah, when it comes to, for instance, taxanes or anthracyclines, regimens used to treat gynecologic cancers, the hands and feet often experience these rashes. And the reason being, because we believe that they develop due to the excretion of the chemo in the eccrine or sweat glands. And there's a high density of these glands on the hands and the feet. They can also develop it in areas which we call intertriginous areas, such as the armpits or the folds of the groin, where there's also a lot of sweat glands.
What is the typical clinical presentation? I know it seems like there's a variety of ways it can present depending on where it's presenting, but what's the typical clinical presentation? I understand, and from my own experience, we would see patients come in and they would say, I have this rash, and that rash could have been caused by so many other things. And how do you kind of narrow down like, oh, it was chemotherapy that caused this, and it wasn't just like coincidental timing that you developed this rash?
Right. So I think a lot of it depends, and this is true, I think, when you approach any potential drug rash on the morphology or the type of lesions that develop, the location of them, and the association between the drug that's given and the rash development. Also, it's very important to note that it's very important to be knowledgeable as a healthcare professional on which types of chemos and other antibiotics, for instance, that are associated with what types of rashes. That kind of helps do some of our detective work. So, for example, for hand-foot syndrome, patients might often present with redness and swelling of the hands and feet. Occasionally, they can blister and be quite painful. When it comes to the nail changes, you'll notice that the nail plates are lifting up from the underlying nail bed. And then underneath the nail plates, you can see some bleeding under the nail. And so that is a classic presentation of taxane nail changes, for instance.
How do you counsel patients who are undergoing chemotherapy? They're already undergoing such a difficult time in their lives, and probably experiencing other side effects. So how do you counsel them through this?
Yeah, this is a really important endeavor and one that I believe falls beyond the dermatologist, one
Mhm.
that really involves the entire cancer team. And that could be the nurses who are sitting with the patients at the infusion centers, the oncologists, the advanced practice providers, because oftentimes we don't see these patients until they already present with their rashes. And so I've been working on this at my cancer hospital via many different strategies. One is giving lectures to all of the members of the cancer teams so that they can educate cancer patients. One of my research fellows now is working on developing pamphlets, which can be distributed to patients who are at risk of getting these reactions because they're on a regimen which we know just has such a high frequency of skin, hair, and nail toxicities. I think all of that is important. What's also interesting is that some of these rashes or nail changes can actually be prevented. And so one of the major breakthroughs, for instance, has been the use of the cold cap for cooling of the scalp during certain chemotherapy regimens, such as taxanes and anthracyclines for breast cancer patients. And randomized controlled trials have shown that this can actually reduce the frequency of the patient getting alopecia or hair loss. Now, I'll say there are certain challenges with scalp cooling, and those can include the high price of it. It's not universally covered by insurances, but oftentimes there are organizations out there who are looking to help patients and sponsor some of these. And also, depending on the regimen, it's not always highly effective. Certain regimens just have a very high frequency of, for instance, losing your hair, known as anagen effluvium, and the scalp cooling really might not be that effective for certain regimens.
Okay. That's very interesting, especially because I'm currently doing hair loss. So, how often are you finding patients are being taken off chemo because of their reaction?
So this is a really important area of oncodermatology, which is, by the way, the name of the field that has developed to really provide specialized care to such a large population of patients. And we've studied this. We've studied this at my institution, at other premier cancer centers, and we know that with early dermatologic intervention, the patient actually can often resume their cancer therapy. It's really only a minority of cases who present with very severe rashes or life-threatening rashes where cancer therapy might be held. So examples of those, for instance, would be like Stevens-Johnson or toxic epidermal necrolysis, which we don't see very frequently from cancer therapies, but they can occur from cancer therapies, including some of the newer targeted and immune checkpoint inhibitor therapies. But to answer your question, the vast majority of patients were able to kind of treat their skin, hair, and nail problems and keep them on their cancer therapy.
So it sounds like early intervention is very important.
Mm-hmm.
What is your threshold for biopsying? I'm sure many times, and you've been doing this for quite a while, a patient comes in and you are no right away, oh, this is from this chemotherapy drug. At what point do you say, like, I really am not sure? I think this calls for a biopsy.
So I would say a lot of it depends on the presentation. So for instance, one of the most common presentations of rashes that I see in my clinic are from the epidermal growth factor receptor inhibitors, which is a type of targeted chemotherapy that has been used in many different types of cancer. And so these patients will present with an acne rash, and they have these red papules and pustules, which look like pimples. And it really favors areas that have lots of sebaceous glands, like their scalp, their face, their chest, and their back. And so when we see that presentation in a patient who was recently on a medicine like cetuximab or panitumumab, we know the diagnosis, and we also know how the patient needs to be treated or should be treated based on recommended guidelines. So that would be an example of a case where I wouldn't do a biopsy. But we do occasionally use additional tests to help rule out other things. So for instance, the acne rash can be superinfected, meaning Staph aureus, and it can be both MRSA and MSSA, which is the non-MRSA type, can get superinfected. So in these types of presentations, we might perform what's called a superficial wound culture to make sure that the antibiotic regimen that we have the patient on is going to be effective. And for instance, the bacteria won't be resistant to the doxycycline or minocycline that we used. Going back to your question, I would say that if a patient presents with a rash that is unusual, meaning it doesn't fit the standard deviations of what we see, or if the rash isn't responsive to our first line recommended therapy, that would be an indication to do a biopsy. We also would biopsy early on if we're worried about this evolving to a severe or potentially life-threatening rash, which fortunately we don't see too often, but that which can occur. For instance, if a patient's on an immune checkpoint inhibitor and develops blistering of the skin, we would do a biopsy to confirm the diagnosis and rule out evolution to severe rashes.
You mentioned checkpoint inhibitors like PD-1 or targeted therapies that are being used more frequently now, especially for treating melanoma. How often are you seeing an increase in skin eruptions due to these drugs?
So what we're seeing is more patients go on these drugs. And so we're seeing more of these eruptions. I wouldn't say that the frequency of the rashes is increasing because, this is something that we've studied. For an example, a patient who's on, as you called, a PD-1 or a programmed cell death 1 monoclonal blocking antibody, a minority of patients we know will get what's called a lichenoid rash, or a rash that looks like lichen planus, which is a dermatologic condition. And so it's not that as more PD-1 therapies given, the frequency of the lichen planus rash increases. We know that it may only develop in 1 out of 3 or 1 out of 4 patients, or even less, but we're seeing it more, to answer your question.
Do you think there's any benefit of starting someone on like a prophylactic treatment, like knowing like, okay, you're going to be starting a checkpoint inhibitor, just to avoid any complications, we're going to also start you on this, or is that a no-go?
So that's a really important question. And I would say that in the example of the checkpoint inhibitor rashes, we encourage patients to use lots of emollients or moisturizers, gentle skincare, because we do know that these checkpoint blockers can cause eczema of the skin or dry skin and itching. Importantly, there have been studies that are out there that have shown, for instance, for the EGFR inhibitor rash, the acne rash that develops, that if you put patients before, as they go on their treatment, preventively on a medicine like doxycycline, and if you prescribe for them a topical steroid, and you encourage them to avoid the sun and use sunscreen, that can actually reduce the severity of these rashes. So they won't stop the rashes altogether, but at least it seems that they will help reduce the severity of it. And oftentimes that can really be key.
What are the top drugs that you're seeing causing skin eruptions?
That's a really good question. So I think that you kind of have to take a step back and break it down into the categories. And so for the chemotherapy drugs, we definitely see lots of rashes from those used to treat gynecologic cancers like anthracyclines and taxanes. Those are definitely some of the larger culprits. Some of the other cytotoxic medicines that are used to treat other cancers like pancreatic cancers, gastrointestinal cancers, 5-fluorouracil, we see lots of rashes from those drugs. When you look at the targeted classes of cancer therapy, and there's many different targeted drugs, I would say the EGFR inhibitors still remain the most common, but there's many other what we call tyrosine kinase inhibitors that block specific enzymes that can cause a whole slew of rashes, which are similar to hand, foot, and others. I'd say the immune therapy, we see lots of rashes from the PD-1 and PD ligand 1 blockers. And in particular, patients are on what's known as combination therapy with the 2 different classes. They seem to get a higher frequency and severity of rashes. And then there's a whole other category, which we didn't really discuss yet, and that is radiation therapy. Radiation therapy, which is used to treat maybe 50% of all the cancer patients out there, can result in many different complications of the skin. So nearly everybody who receives radiation therapy will get some sort of radiation burn, as some patients refer to it, or radiation dermatitis. And going back to the preventive question, we do, and this is something maybe we were going to talk about later, we do know for radiation dermatitis, using topical steroids, for instance, for patients who are receiving it for breast cancer, can also reduce the severity of it.
I had a patient who had a cancer, and he had radiation therapy to his scalp. Mm-hmm. And he ended up with radiation dermatitis as well as alopecia, which is very difficult to treat. Do you have any experience with these types of patients?
Yeah, sure. I mean, when patients develop what we call persistent or permanent alopecia, which can be due to certain chemotherapies or radiation therapy, especially of the scalp, this can be really, just a devastating side effect for patients. Sometimes they're aware that it may happen, and sometimes it really wasn't on their radar. And we really know that this impacts them both physically and emotionally. So our approach is usually using medicines such as topical minoxidil, which has been studied for these types of conditions, and that is actually an over-the-counter that's known as Rogaine. We've also started to explore the use of oral medicines, pills that can be taken. And for instance, there is a pill form of Rogaine known as minoxidil, which is being studied for these types of disorders. And it also brings us to a really interesting and somewhat controversial area, and that is it safe to give patients who have hormone positive cancers, like for instance, breast cancer, that might be estrogen receptor positive, oral medicines that can potentially impact the hormones, such
Like
as,
dutasteride?
yeah, exactly, like finasteride, dutasteride, or even spironolactone. And so this has been an area that's also been explored, and it seems to be that the impact of these medicines on hormone levels isn't so straightforward. So it's not necessarily going to increase the estrogen levels, which then might be concerning for driving a cancer. But more work needs to be done in this area. So I would say for now, I usually start with things like topical minoxidil, and then I might consider doing something like oral minoxidil if the patient doesn't have any comorbidities, which might prevent them from being on it. For instance, cardiovascular disease or arrhythmias.
So you're saying it's better to start with topicals and then go from there.
Yeah, I think that depending on the side effect, that's kind of an approach that seems to make sense for treating a lot of these disorders. You know, if a disorder presents as what we call lower grade, and we're able to grade these based on recommended guidelines, then we might start with something such as topicals or oral antibiotics, depending on what the rash is. And then if it's really presenting at a higher grade or potentially life-threatening, that's when we have more aggressive interventions, such as systemic steroids, hospitalizing the patient, treating severe superinfection, to give some examples. The latter group also being the group where we might be more likely to hold their cancer therapy until the rash gets under control, and then have a multidisciplinary discussion about whether the cancer therapy can be reinstituted.
If a patient has a treatment interruption, how long do you usually wait to restart the medication?
A lot of it depends on what the rash is. Many times, just a very short drug holiday, we call it, where they might miss maybe 1 or 2 infusions. And sometimes these infusions are given every 3 or 4 weeks. You know, the patient might be off of it for a month or two. And then, especially if it's a very severe rash. And then once the rash goes to low grade again, the patient might go back on it. Also, sometimes depending on the class of drugs, for instance, the targeted therapy drugs, the ones that are oral medicines, and some of them are, the oncologist might try a lower dose, because some of these side effects are dose dependent. And so an example of that would be if a patient develops hand-foot skin reaction, where they get very painful red calluses, which can also blister, and the patients also have like a tingling pain on their hands and feet, especially in areas of pressure. That would be a type of rash which tends to improve on a lower dose. And so that's an example of that strategy. So there's no one universal strategy. A lot of it depends on the type of medicine, the patient's overall status, the ability of them to be on a short break if things are going well, which sometimes is the case, versus they really need the medicine. So it can be complicated.
Every patient's different. Is it, do you usually see like skin eruptions early on in their course of chemotherapy, or does it usually take longer to develop as it builds in their immune system?
So again, another good question. Also depends on the type of cancer therapy. So for instance, you mentioned immune system. So the immune checkpoint inhibitors, the PD-1 blockers, the PD-Ligand-1 blockers, many of the most common rashes that we see actually develop months into treatment. For instance, the lichen planus rash can develop several months into treatment. They don't always develop right away. Some of the less common rashes, such as blistering disorders, known as bullous pemphigoid, can occur from these checkpoint blockers, as well as many other types of autoimmune or immune-mediated processes, as you mentioned. And these can actually take several months, sometimes even a year or so to develop, which is really interesting. A lot of the other rashes that we see, for instance, the acne rash from the EGFR inhibitor targeted class of of cancer therapies, those tend to occur pretty rapid onset within the first few weeks of the patient being on the medicine.
Have you had any patients come in who have been off chemo for like a year or two and they suddenly develop a rash, or does that not happen?
It's not common. It has developed. I have had patients develop bullous pemphigoid even a year after being off of their immunotherapy, or a year or two after starting their immunotherapy, develop it much later on. I think it's complicated as to why, the pathophysiology, why this happens. The immune mechanisms are complicated. There's many theories. Some of these can be driven by other stimuli or antigens in the body, such as other medications or the patient's changing immune system. And so I think that there are lots of great areas of exploration to be had in this area. Yeah.
Are there any risk factors associated with the severity of the dermatologic condition that someone develops, or even predispositions to developing them?
Yeah. So again, yes. For instance, patients who have underlying disorders like eczema or psoriasis, they might have or an autoimmune blistering disease like bullous pemphigoid. Those for sure might flare during treatment. Now, studies have shown it's not all the patients who have these disorders will flare, but for a lot of the more serious rheumatologic disorders like lupus, a substantial percentage of these patients might have a very serious flare requiring aggressive treatment. For other rashes, like for instance, radiation dermatitis, we do know that there are, in addition to the factors of the type of radiation they receive in the body area, there are factors of the patient which can play a role. So patients who have, let's say, larger skin folds that are more prone to getting radiation dermatitis, higher BMI, obesity, patients who are smokers who have connective tissue disorders, they might be at increased risk of some of the longer term chronic radiation changes we see. So there certainly are, but unfortunately for a lot of the different types of rashes that we see, there seems to be no clear risk factor that a patient might say, oh, well, I have this risk factor, so I better be careful. Unfortunately, there's no blood test yet before they go on medicine to say, oh, I have this, genetic class of, HLA, and I should be, worried about developing this sort of rash. I think a lot of people are exploring that, but there's nothing there yet.
So is that where the future is going?
I don't know. I think that it would be great. One of my greatest wishes about treating patients who have reactions to drugs, including chemo, would be if there was a blood test to tell you, this is the drug, and this is what's going to develop. This is what, and so we don't have that yet, but I do think people are working on it.
What is the pathophysiology of developing the most common skin eruptions?
Yeah, again, I think we spoke a little bit earlier about toxic erythema of chemo from, chemo is used to treat breast cancer, for instance, and those seem to be a direct toxic effect on the sweat glands. Some of the other classes, for instance, the epidermal growth factor receptor inhibitors or the EGFR inhibitors, as we refer to them as, that seems to involve the fact that epidermal growth factor receptor is really important in maintaining normal skin, hair, and nail homeostasis. So that receptor we know is really important to maintaining inflammation, skin barrier, transepidermal water loss, host defense against microorganisms. And so it's no surprise that when you inhibit it or dysregulate it, that you'll get all these different toxicities of the hair follicle, such as acne, pustules, staph bacteria, dry flaking skin, eczema. So I think the mechanism for the EGFR inhibitors involves the receptor. I think a lot of it depends on the type of cancer therapy. Radiation, for instance, is a direct effect of the radiation causing DNA damages in the skin, and then many other complications can develop. So I think it's a great question. Really depends on the underlying, cancer medicine.
Is there anything else that you would like to add, Dr. Leventhal, about either your research going on or where the future is?
Yeah, I think that this is kind of, what one of the missions are of what we do. Dermatologists who work at cancer centers and really help patients who need us, cancer patients who develop these serious complications. I would say that dermatologists play a really important role, not just those that work at cancer centers. A lot of patients are going to be getting these medicines as they become more frequently used, especially the newer targeted and the immune checkpoint medicines. And being knowledgeable about them, the different rashes that can occur is really important. We make a really big difference. Picking up the phone, talking to the oncologist, having a discussion with the family really goes a long way. So I think that that's one of the messages. The other message is that these rashes, many times they seem as though they may not be really important to the patient's overall health, and treating the cancer is the primary goal, right, of oncology practices. However, we do know from studies that young women, for instance, who develop nail changes or hand-foot syndrome or hair loss, it really impacts them, not just physically, but also emotionally. It can cause depression, anxiety, it's a stigma. And so I think just being really cognizant of that and showing patients that this is really important, we care, we can help, goes a really long way. It's one of the things that I enjoy most about what I do. And so I hope that dermatologists will continue to follow that path, especially those who are graduating residency, looking for jobs. Working at an academic center, treating cancer patients is a really great and rewarding subspecialty.
Thank you so much, Dr. Leventhal, for joining us today and for taking the time to share with us your expertise and knowledge. It helps a lot. I know it resonates with me, having many members of my family being cancer survivors. So thank you for taking
Yeah,
the
of course.
time today.
Thanks for having me. Thanks for doing this.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.